Hi, we will be talking about the national scenario of palliative care in India. The lecture has been prepared by Dr. Mona Rai, Assistant Vice President of National Association of Palliative Care for Ayush and Integrative Medicine. So, we have already covered the history in earlier slides. In India, what is the current status like? The 2015 Economist Intelligence Unit report on quality of death experience in 80 countries has placed India shamefully low on 67th position. Published in the Lancet Global Health, the study found that by 2060 an estimated 48 million people annually will die with serious health related sufferings, representing an 87% increase from 2016. It is estimated that 5.4 million people a year are in need of palliative care. This is an enormous burden in India. Every year, more than 60 patients die in India from cancer and in agonizing pain. It is estimated that 60% of the people dying annually will suffer from prolonged advanced illnesses. Less than 1% of 1.3 billion population has access to pain relief and palliative care. It is estimated that 1 million new cases of cancer occur each year in India, with over 80% presenting in stage 3 and stage 4 when palliative care is required. So, this chart is showing the palliative care development internationally as well as in India. Palliative care was born in India at Shanti Avedana Sadan in Mumbai, a hospice in 1986, and Community Oncology Center and Hospice in Ahmedabad in 1988. Pain and Palliative Care Society established in Calicut in South Indian state of Kerala in 1993. Indian Association of Palliative Care was conceived in 1994. In 1987, Cancer Aid Society was incorporated at Lucknow. Late 1990s had several new palliative care initiatives as Guwahati Pain and Palliative Care Society in Assam, Jivodaya Hospice in Chennai, Can Support in Delhi, Lakshmi Palliative Care Trust in Chennai, Karunashray in Bangalore. The neighborhood network in palliative care in Kerala was developed in 2001. In April 2008, Kerala became the first state in India to announce a palliative care policy. So, this was a landmark step. Medical Council of India accepted palliative medicine as a medical specialty and announced a postgraduate course in 2010. This was on the eve of international conference being organized at Lucknow by Cancer Aid Society. In 2012, the first Doctor of Medicine course was started at Tata Memorial Hospital in Mumbai with 2 places per year. The Ministry of Health and Family Welfare, Government of India constituted an expert group on palliative care, which submitted its report proposal of strategies for palliative care in India in November 2012. The National Program of Palliative Care for India came out in 2012. In February 2014, the Parliament passed the NDPS Amendment Act. The new act transferred the powers for legislation on essential narcotic drugs from the state governments to the central government. The Pune Declaration 2016 appealed to the Indian government for adequate funding for timely and effective implementation of NPPC 2012. The NDPS Amendment Act 2014 also inclusion of palliative care in undergraduate medical and nursing curriculum. McDermott et al. Identified 138 organizations currently providing hospice and palliative care services in 16 states or union territories. The Kerala network has more than 60 units covering a population of greater than 12 million and is one of the largest networks in the world. Currently, there are over 908 palliative care centers in India. Palliative care services in Kerala are 841 centers out of 908 centers all across the country. Some regional cancer centers like Trivandrum, Bangalore and Delhi, which already had pain management programs, also included palliative care in their services. So, what is the strategy of NPPC? The objectives of National Palliative Care Strategy is number 1, to improve the capacity to provide palliative care service delivery within various government programs like National Program for Prevention and Control of Cancer, Cardiovascular Diseases, Diabetes and Stroke, National Program for Health Care for the Elderly, the National AIDS Control Program and National Rural Health Mission. Refine the legal and regulatory systems and support implementation to ensure access and availability of opioids for medical and scientific use, while maintaining measure for preventing diversion and misuse is point number 2. The third objective is encourage attitudinal shifts amongst healthcare professionals by strengthening and incorporating principles of long-term care and palliative care into the educational curricula of medical, nursing, pharmacy and social work courses. The fourth point is promote behavior changes in community through increasing public awareness and improved skills and knowledge regarding pain relief and palliative care, leading to community owned initiatives supporting healthcare system, and this NPTEL course is targeting towards that. Encourage and facilitate delivery of quality palliative care services within the private health centers of the country is agenda number 5. And the sixth point is develop national standards for palliative care services and continuously evolve the design and implementation of the national program to ensure progress towards the vision of the program. These are the references which you will be getting in the resources. So, if you want any further reading, you can refer to the resources section. Thank you.